We'll get started. I know folks are still joining. My name is Rebecca Wallach. I'm the director of the Evelyn Frank Legal Resources Program at NILAG. I'm joined by Kelly Ann Murray, supervising attorney in our unit, and really our Medicare maven and expert on Medicare open enrollment. We have a lot to get through in this hour. We're going to do our best to get through everything and hopefully hold questions till the end, although you can use the questions and answer function during the presentation and we'll do our best to answer. Two common questions. Will these slides be available and will the webinar be recorded? The answer is yes and yes. We will be posting this hopefully on YouTube later this week. And additionally, we will send out a PDF copy of these slides for those who registered through Zoom. So let's jump in. NILAG, New York Legal Assistance Group. It's a large civil legal services organization serving low-income New Yorkers in New York City. And our unit, the Evelyn Frank Legal Resources Program, is focused on fighting for older adults and people with disabilities to have access to affordable health coverage that covers the services that they need. And we meet this mission in a variety of ways. We have one-to-one client cases where we're counseling clients or fighting on their behalf in fair hearings against the Medicaid program or managed long-term care plans. And we are also conducting trainings like this one for social workers, attorneys, consumers, and family members, and participating in public policy advocacy. We have a wonderful website called nyhelpaccess.org, where we do our best with our sister organizations, Empire Justice and Legal Aid Society, to keep the state apprised of changes with the Medicaid program, which right now, those changes are coming at us at an incredible rate. So if you haven't been to this website, I encourage you to do so, nyhelpaccess.org. So why are we focusing on Medicare open enrollment and plan options right now? Well, the reason is it's because from October 15th to December 7th, every year, it's the Medicare annual open enrollment period. This is the time of year where Medicare beneficiaries can assess their Part D prescription drug plan or their Medicare Advantage plan to see if they should stay in it or switch plans. And those changes will be effective January 1 of the following year, which for us means January 1, 2026. For many, if not most Medicare beneficiaries, this is the only time of year that they can change plans to make sure that they can afford their coverage the next year. And there are a lot of reasons why Medicare counseling is so important. First, it ensures that our clients and the people that we're working with have access to adequate health care, that all of their prescription drugs are covered with the lowest costs, with the fewest utilization controls, and at the client's preferred pharmacy. And for a lot of New Yorkers, their pharmacist is part of their care team, and it's someone that they really rely on and trust. For those who are enrolling in Medicare Advantage, and we're going to define all these terms later on, we need to make sure that the plan that they're in covers their primary care and specialist physicians. It's also true that plans that existed in 2025 might not exist in 2026. It's true that if you don't switch plans, you may end up paying hundreds of dollars more a month because your prescriptions aren't covered or because of the out-of-pocket costs for those particular prescriptions are very high. It's a time of year, too, where we can look at trying to combat the affordability crisis that we know is out there by screening clients for additional benefits, whether it's EPIC, the Medicare Savings Program, Medicaid, Extra Help, SSP, and SNAP, which we know is in a tight spot right now because of the government shutdown. We will try to touch on all of these benefits at the end of the presentation. Truly, the entire system really relies on active annual participation. Every year, the plan choices change, and really every year, a Medicare beneficiary acting as the rational consumers that we all are, should evaluate their coverage for the next year. But we have a site here that KFF reported that really only 30% of beneficiaries are comparing their coverage annually. And so we can all be a part of hopefully increasing that number. Big takeaway, the time to act is now. It's October 29th, and the open enrollment goes only through December 7th. So don't wait, act now. Of course, keeping that in mind, acting now, there are always exceptions to the rules when it comes to healthcare, navigating healthcare coverage in the United States. And so there are special enrollment periods, which we call SEPs. These are limited circumstances that allow a Medicare beneficiary to switch plans. There are our partners at the Medicare Rights Center or even Medicare and Medicare.gov have very detailed charts that we've put in these slides that will be provided to everybody who's participating that you can review for possible SEPs after January 1. If a client were to come to you after January 1 with a problem with their coverage, which we hope they won't do after you attend this training. For a lot of our clients at NILAG and possibly other organizations that are participating in this webinar, a major SEP is for those who receive extra help, the Medicare saving programs, or they're enrolled in the Medicare savings program or Medicaid. And this SEP allows that once a month, an individual, if they're enrolled in one of these benefits, can change from one Part D plan to another, or they can disenroll from a Medicare Advantage plan and switch to original Medicare, or they can switch between certain integrated dual eligible special needs plans. They cannot switch into a Medicare Advantage plan. We also wanted to make sure that people were aware of a new SEP for 2026 that CMS has instituted. It's for people who experience a service disruption due to an inaccurate provider directory. And we'll get into more about what this means when Kelly discusses the Plan Finder tool. And for those, there is a Medicare Advantage open enrollment period that happens annually from January 1 through March 31. And it allows a Medicaid beneficiary enrolled in Medicare Advantage to make one change during that time. And there are specific changes that they are allowed to make. They can switch from one Medicare Advantage plan to another, or from a Medicare Advantage plan to original Medicare. But they cannot go from original Medicare into a Medicare Advantage or into a standalone part, or change between standalone Part D plans. And again, it's only one time. So the big takeaway here is to act now. We don't want our clients calling us on January 3rd with big problems and big bills, but just, so this is the time of year to do that, but there could be some exceptions. I'm going to pass it over to Kelly now to make sure that everyone understands all those terms I was just referring to.
So I'm just going to jump right in just to do a quick little refresher about Medicare. Medicare is broken up into different parts. Different letters means different services or providers are covered. So Part A, you're going to go, is any of your inpatient hospitalization, inpatient rehab, it would be covered by Medicare Part A. Medicare Part B is your medical insurance or any of your outpatient services, including your doctor visits or your doctor care in the actual hospital. I'm going to skip over to Part D. This is the easiest part to remember. D equals drugs. It's how your Medicare prescription drug coverage, or how when you go to the pharmacy, your prescriptions will be covered. And then there's Part C, which is really a combination of A, B, and C, or also known as Medicare Advantage through a private health insurance plan. Next slide. So it's just important to remember that people are going to tell you, well, I have Medicare. And that's great. You have Medicare, but we have no idea how your actual care and services are covered, because there's many different types of plans or health coverage is actually provided. Next slide. So there's two options for coverage. You have original Medicare, so that's your red, white, and blue card. You're going to go into the doctors or you're going to go into the hospital and you're going to have your red, white, and blue card, and that's going to cover your care in those locations. The federal government will be billed. Anyone who is accepting Medicare contracts with the federal government to provide that particular care. There's usually no networks, no referrals, and some very limited prior authorizations. Then an individual may have another insurance, which is their prescription drug coverage. Now, how they get that drug coverage, we will go through in a little bit. But it usually means that when a person says, I have Medicare, and they look at you with a blank stare, you're going to ask them, do you have your insurance cards with you? And they're going to hand you two cards, a red, white, and blue card, and then an insurance card that says on the corner Medicare RX, which is your drug card. Then there's the other option, Medicare Advantage. It's through a health insurance plan. The person chooses to enroll in that particular plan, and the federal government's going to pay them a capitated rate for the enrollment. All of their doctors will contract with that particular insurance company, or there might be some out-of-network coverage depending on the plan. And that plan will also cover your Part D drugs. Most times you will have to stay within the network. You might need referrals, you might need prior authorization for particular services. It does also sometimes provide you with additional perks that original Medicare won't cover. Next slide. In addition, when we were talking about original Medicare, some individuals may decide to purchase what you call a Medigap policy. A Medigap policy is a Medicare supplement that supplements Part A and B. It will not supplement your drug coverage, but it will supplement you when you go to the doctors. Meaning, I go to the doctor, I hand my red, white, and blue card, and then I'm going to hand the Medigap policy. The Medigap policy, although through an insurance company, does not have a network. It just wraps around your Medicare coverage so that you will not have to pay the full cost of your particular share. Just note, Medigap policies are usually very expensive. And we did provide you with a link when you get the slides that will provide you with the lists available for your standalone drug plans and also your Medigap. Oh, I just went through that. Just so you know, your Medigap policies are broken up into letters too, because they like to confuse you. Letters A through N. Some of those letters are no longer available or only available for people if they had Medicare at the time in which it was available. Next slide. So how a person gets a prescription drug is going to depend on if you have original Medicare or Medicare Advantage. Next slide. So your Medicare Advantage, once again, it's your red, white, and blue card, your original Medicare, plus your Part D plan. Two cards, two different types, two different services are covered by these cards. One, the red, white, and blue card, doctors, hospitals. Your prescription plan will cover your prescriptions. However, if you're in a Medicare Advantage plan, most of those plans do have drug coverage, and you will be using the same insurance card for both visiting the doctors and going to the pharmacy to pick up your medications. Next slide. However, if a person is getting their drug plan through their union or retiree plans, their coverage is not through Medicare. However, it's a Medicare-like product, so you will get some people who have union or retiree coverage that will have a Medicare RX on the corner. So it's important that you say to the person, how is this paid for? How did you get it? They'll say, oh, my former employer gave it, or I go through the union to get it. Those coverage is considered to be credible, so you don't have to get a separate Medicare Part D plan. Usually your retiree or your union is paying any premiums for it. It's just part of your retirement packet. However, if a person has their coverage through the union or retiree, they should not do anything at this point. Medicare open enrollment is not for them. They need to call their benefits administrator, their union representative, their union or the human resources, because those particular plans usually have their own separate open enrollment. You don't want to change that coverage unless they have an in-depth conversation with their union or retiree, because if they switch, they may not be able to get that contract, that insurance back. So you would proceed with caution. You just want to know, how does the person have the coverage, union or retiree? They need to go speak to their plan administrator. So a lot of people, when they say I have Medicare, they'll then say, well, I have Empire Blue Cross Blue Shield doing business as Anthem. And then they look at you and they expect you to know what that means. Just because they have insurance through Anthem doesn't mean that their coverage is the same as someone else who has their coverage through Anthem. So insurance companies offer an array of plan options that vary on benefits, also vary on how they actually get their coverage. Next slide. So it's important to say to them, okay, can I see your card, or look at the name that's actually on the plan? Because then you'll have a better basis to know exactly what this coverage is for. Somebody might tell you I have AARP, but AARP could be just a standalone drug plan, could be a Medicare Advantage, or could be a Medigap. All of those covered services and providers in different ways. So just because they give you an insurance name doesn't mean that you'll be able to better advise, or you yourself will be able to figure out, this is the best thing for me. Next slide. So I always laugh at everyone who can't wait to turn 65, because once they turn 65, they're going to get Medicare and health insurance, and healthcare is going to be free, or at least really, really cheap. And unfortunately, that is not true. Medicare is not free. So Medicare has out-of-pocket costs for all the beneficiaries. There might be some cost savings or programs that will help reduce those, but just if everybody started at the first start, everybody would be looking at a monthly premium, which is like your membership fee. I pay X amount of dollars, and then I get Medicare Part B. And then there's a deductible. So I have my card and I'm very excited to have my card, but the card says to you, that's great, but now you have to pay X amount of dollars. And once you reach that magic number, what's going to happen is my insurance is going to kick in and you're going to be able to pay. Then the insurance will pay a particular amount and then you'll pay the difference. So you have your premium, like your membership fee, your deductibles, like your entrance fee to get through the door. Once you've gone through the door, you're going to be looking at a copay or a coinsurance. Copay meaning a specific dollar amount. I go to see the doctor and I pay $20 copay. Or a coinsurance. I go to the doctor and I pay a percentage. I pay 20%. And then finally, when you're looking at Medicare Part D, your out-of-pocket costs are going to be determined by whether it's in-network, meaning the pharmacy's in-network, or that particular prescription medication is on the formulary list, their approved list for the particular drugs in which you take. There's thousands of drugs out there. Each plan does not cover all thousands of drugs, but they do have to cover a set number of medication in each classification of the prescription. So I might cover 10 medications that are in the classification for high blood pressure, but I don't cover all 100. that might be on the list. Next slide. So unfortunately, the 2026 costs for original Medicare have not been released. It's a little delayed. It was expected to have been released last week and it has not come out as of yet. Hopefully it will be soon. Hopefully they're not waiting for the federal government to reopen. However, these are the numbers for 2025. Most individuals are not paying a premium for Part A. If you have a work history of 10 years or more, then you don't have to pay a premium. If you have less than 10 years of a work history, there is a premium depending on the number of years you work. Part B will have a premium of $185 for everyone who has Medicare. If you go into the hospital, Part A, there is a deductible. The first $16.76 you will pay. That will cover you up to day 60. So if you're only there for one day, it's quite expensive. If you're there for 60 days, you can't even stay in a hotel for that amount. It would only be $16.76. Of course, the doctors get billed differently onto Part B. Part B has an annual deductible of $257 currently. And then you have co-insurances for hospital days after your deductible of the first 60 days. And also you have co-pays for inpatient rehab after day 20. Basically, Part B will break out to when you go into the doctor in January, because everybody remembers in January and then you forget because you don't remember paying the first $257 when you go to the doctor. So the first $257 is paid directly to the doctor from you. You get billed. Once you reach the magic number, it will go to Medicare, will pay 80% and you will pay 20%. If you have secondary insurance, such as a Medicare supplement, that 20% amount will be reduced depending on the coverage that you have. Next slide. The costs related to Medicare Advantage are publicly available now. Individuals who are in a Medicare Advantage plan do pay the Part B premium of $185. And then there might be an additional premium depending on the plan. And that would be will break down into whether there's a health portion premium or a drug portion premium. Currently, the average premium for Medicare Advantages in 2026 will be a little less than $41 a month. And once again, that's in addition to the $185. The good thing about a Medicare Advantage is it's predictable. When I said earlier about Medicare Part B, once you've reached the deductible, it's 20%. You have no idea what 20% of reasonable cost is. So there is some uncertainty of how much your doctor visits will cost. Whereas in a Medicare Advantage plan, each plan will set their copay structure so that you know once I've reached the deductible, or if this visit is not subject to the deductible, then I will pay this particular copayment amount. Once again, in a Medicare Advantage plan, there is whether they're in network or out of network. If it's a PPO plan, which allows you to go fluctuate between in network and out of network, there'll be two different copay structures. In that, if you're out of network, you will pay a high amount. If it's an HMO, you are not going to be able to go out of network. And if you do go out of network, you'll be paying 100% of the cost of the visit. A good little perk for a Medicare Advantage plan is that they have what you call a maximum out-of-pocket limit, which means once you've reached this magic number that you've paid to your doctor's hospitalization, you will have no additional co-payments for the year. So it allows you if God forbid you have to go to the doctors a lot or you have to go to the hospital a lot, it tells you once you've reached this magic number, your care is going to be free. The good news is there is a magic number. The Bad news is that, the maximum amount for the majority of the Medicare Advantage plans is $9,250. Nobody wants to be able to reach that number, but if you do, and that's your copay, not what the insurance paid, but what you paid out of pocket, then you get to pay nothing. There is a cost analysis. When I was discussing original Medicare, I told you that you could purchase a Medicare supplement. Those supplements are costly, but if you were to do an analysis, a financial analysis, none of the 12 months of a Medicare supplement is not as high as this maximum out-of-pocket costs. Just a matter of how you want to chance it and or pay for your care. Next slide. So that was your Medicare, original Medicare, that was your Medicare Advantage, that was basically for any of your medical care. Then we have Part D costs related to your prescription medications. A Part D plan will have a premium. Some of the Medicare Advantages plans do have a drug premium, and then you'll have a deductible, which is the amount that will your insurance will start paying at, and then a copay. And then your copay is going to depend on a whole bunch of different issues, because we don't like to make this easily. Formulary, is it on your approved list? If it's on your approved list, do you have to jump through any hoops? Is there a prior authorization? Is there a step therapy, meaning I want to take this medication, and then the insurance company says, I understand that, but we want you to try this medication first. If you've previously tried it, we need the doctor to tell us why you can't start with A, but you need to jump directly to B. And then quantity limits. I take 30 pills. The insurance company says, okay, that's within the limit. We will only authorize 30 pills a month on that particular drug. If it's more than that, then your doctor is going to need to give us additional information as to why you need more than the number of pills we believe you should only be taking. Then there's drug tiers. That means that they usually have a 5 or a 6 level tier program where, starting with your generics, you start with your preferred generics, and then you go your standard generics, and then you move down to your preferred brand, your standard brand, and then you have your specialty medications. Depending on the drug tier will depend on how much it costs. Of course, if you start at tier 1, it's going to be your cheapest medications with copays. As you go further down in the tiers, it's gonna the money out of your pocket is going to increase. And then finally, it's the stage of coverage, where you are in the year. Did you do deductible, or did you in your regular standard, or are you at your maximum out of pocket, or the ceiling limit for how much you're required to pay? Next slide. So currently in New York State, there's 10 insurance plans that are offering Part D drug plans. Last year there was 12. So 2 of them have closed. You have a wide variety of premiums. The average premium costs $107. The lowest premium per month is $35.70. The highest premium is $173. Most of the plans have deductibles of $615. One plan has a 0 deductible, which you can guess has the highest premium of $173. Then we reduce 2 other plans to have less than $615. If a person has extra help, whether they get extra help through Medicaid, through the Medicare Savings Program, or they've applied directly with the federal government, their deductible will be 0. Next slide. And Rebecca's going to go through extra help later on, but as I said, extra help is a program through the federal government that helps you with your drug plan costs. They do pay what they call a basic premium assistance. In New York, we currently have 3 benchmark plans, which means anyone on extra help is paying zero premium for these 3 particular plans. In 2026, that amount will be decreased by 1. So if you know of anyone or you yourself have SilverScript Choice RX, you need to act, or else on January 1, you will be paying an additional $57.20 if you're on extra help, or you'll be paying it's $116 for individuals without extra help. So SilverScript is increasing, and there are plans that are increasing just as well with $50. We did have a few plans that decreased their monthly premiums also. Next slide. So I did allude to that there's a Part D cap or MOOP, but it's not called a MOOP, it's just called a cap. And so when a person reaches the maximum amount of out-of-pocket costs in Part D, so when you reach $2,100, not including the premium, what will happen is your medications will cost zero amount of money. Once again, the good news is when you reach $2,100, your premium, your co-pays or co-insurance will be zero. The bad news is you have to pay $2,100 for the year before your premiums are zero. But at least there's some light at the end of the tunnel when a person has expensive medications. Next slide. I think I'm handing it over. We're teaming Medicare. There's just too many ins and outs, so I'm handing over the baton to Rebecca.
And we're trying to give Kelly a breath. You get a sense of how complicated this is and how much knowledge we need to have as advocates to help our clients navigate the system, but also how much is expected of our clients to understand the system so they can be rational consumers and pick the best plan for them. Before we go back to Kelly to really talk about how you choose a plan and the plan finder tool, we wanted to spend just a little bit of time on certain changes to the Medicare program overall, but specifically in the Part D realm that have just been around for the last couple of years through the Inflation Reduction Act. And these are strategies that may may lessen the burden of the out-of-pocket costs for clients when it comes to paying for prescription drugs. Kelly talked about the coverage phases in Medicare Part D, and we have the slide that talks about the deductible phase, the initial coverage period, and then the catastrophic coverage. She just finished talking about it. This year, most of the plans, not all, but most of the plans in New York have a deductible of $615 for prescription drugs. That's $615 that Medicare beneficiaries have to pay out of pocket. And then we go into the initial coverage period. That's where after that 615 or whatever the plan's deductible is, there's a copay. It's going to depend on the plan. It's going to depend on the drug tier, everything that Kelly just reviewed. And once you reach that $2,100 cap, it's now $0 for the beneficiary for all drugs. So that cap does make a huge difference. That's new. That was created through the Inflation Reduction Act, or reduced. The people, those of us can remember the donut hole and all of those things. That's gone. This is our new structure for the coverage phases, and it is easier to understand. But even so, a client could have in January a $615 bill that they are required to pay in order to access their meds, and that could be a big barrier. A client could have a $2,100 bill in January, which would also be a big barrier and probably deter a lot of us from seeking our prescribed healthcare. And advocates realize that. And this new program, the Monthly Prescription Payment Plan, or MPPP or MP3, was created as part of the Inflation Reduction Act. It's only been around for less than a year. This year, 2025, was the first time that it was rolled out and established. So 2026 will just be the second year that it was established. And what it allows people, Medicare beneficiaries to do is to spread out the out-of-pocket drug payments throughout the calendar year. So it helps manage the monthly expenses. It doesn't eliminate them. So for example, if you are on oral chemotherapy and in January you have a bill for more than $2,100, but your out of pocket is $2,100, you could use this formula to divide that $2,100 and kind of like pay for your drugs on layaway, right? So you're paying each month a portion of that $2,100. The request for a consumer or beneficiary to enroll in the MPPP program goes directly to their insurance company, so whoever is providing that Part D coverage. And instead of paying the pharmacy, so you are going to pay the plan. So when you go to pick up your drugs from the pharmacy, that's going to be a $0 interaction between you and your pharmacist. You are going to be billed by your insurance company to pay that portion each month. Beneficiaries can opt out. We're not going to go into the formula to figure it out, but we do have the link here to the CMS guidance if you want to figure it out for your client. Here we just have some sort of guiding principles for who might benefit from MP3, who it's not good for, anyone who already has extra help, Medicaid or MSP, because as Kelly said, and as we're going to touch on later, they're not going to have a deductible. They're going to have reduced prescription costs. If a foundation is covering the cost of your prescriptions, this is going to be less important to you. And that's true for certain oral chemotherapies, other drugs for rare diseases. If you have low out-of-pocket costs, this is not a headache that you need, right? And if you sign up later in the year, the benefit to you is going to be less because the monthly amount that you owe to the insurance plan is going to be higher. I think that it's better for people who have big bills early in the year. Last year, we didn't really advise any clients on this program, but this year is the first year we did find a client who we think this might be beneficial for. So just know that it exists and know that it's new, and you can come back and reference that guidance or these slides if you think it might be helpful. But our first tip would be to screen people for Epic, extra help, things like that. Just really briefly, there are free services covered by Medicare. There's preventative screening where there won't be a copay, and we've listed some of them, but not all of them here. We do have a link to that complete list. Mainly, it's your annual wellness exam and cancer screenings, etc. And the Inflation Reduction Act also reduced certain Medicare costs. So $0 cost sharing and no deductibles for vaccines. We've limited the copay for insulin to $35 a month. There are certain requirements when drug manufacturers must provide rebates. We increased eligibility for extra help in 2024, which made a huge difference across the country. And we also, for the first time, have Medicare drug negotiations to reduce the cost of some of the most expensive drugs that older adults and Medicare beneficiaries rely on. So those are all things that are in the works, and they're new-ish changes to the Medicare program. Now I'm going to turn it back to Kelly to jump in on the real details on how you help clients pick these plans.
So once again, as Rebecca told you, Medicare is an active program. You have to figure this out. And you should be reviewing your coverage on an annual basis, and you need to do the research to determine which plan best meets your needs for the upcoming year. Because the worst call I get is going to be on January 4th when the person tells me they went to pick up their medication and either their pharmacy is no longer in their plan or the medication is no longer covered by that particular plan that they had in 2025. So we don't want any shocks, or there might be some people who find out their plan is no longer doing business. So it's time to review. How do you review your coverage options? Well, I'm going to give you some tips. Medicare has your Medicare Plan Finder tool. You're going to go to that website. It's very, very important that if you were to do this search on your own, if you Google Medicare Plan Finder, it might not necessarily get you to the Medicare.gov. It's going to give you about 500 options because the insurance companies have their own Medicare plan finders. And so we want to make sure that you know you need to be in the Medicare.gov website. It's going to pop up. My little friend here is not going to be there. This year's website has 3 lovely ladies. And it's going to come up and it will say, you want to explore your Medicare coverage options. And you're going to fill in each field, and it's personalized to yourself without having to give personal information. Some people do have a mymedicare.gov website, and you can log in. They've just started a 2-step authentication, so I don't know what a headache it is. However, you could always log in without the person's personal information or your own information. You start with your zip code. You hit start. It's going to ask you what type of coverage are you looking for. And then it's going to talk you through step by step. Do you have Medicaid? Do you have the Medicare Savings Program? Are you receiving SSI? Do you have extra help? I don't know what I have. I don't have any of these. Then it's going to ask you to put in your medications. Once you've put in your medications, it will be the name, the dosage, the frequency. If for some reason you start to type and there's not a drop-down menu for that includes your medication, that particular medication might not be covered, or you might be typing the wrong name. But you're going to click it through. It's then going to ask you what pharmacy do you want. It gives you all a pharmacy within 2 miles of this zip code that you've put in. And then it's going to ask you, since you had told them what kind of plan type you want, if it's just a drug plan, it's going to pre-populate and do the search for you, and it's going to come up your least expensive options, which includes the monthly premium plus the annual cost of your medications. If you do a Medicare Advantage option, you'll have to answer a few more fields, which include your name of your doctors. That's new for 2026. It's somewhat helpful. However, it only allows you to enter in 5 doctors. It will ask you, you can add them in, and then when it does its search, the Medicare Advantage plans will come up, and it will tell you of those doctors who is covered and who's not covered. If you have more than 5 doctors, you can do a search and then go back and change your doctors and do a search when you start to narrow down. I recommend that you don't rely just on that you also go into the individual plans to confirm that that information is correct. You want to print all that information and save it somewhere good, because if the information that was provided on Plan Finder and or the plans website and or provided information is not correct in January or February and you relied on it, it's going to give you a step. It's going to give you that opportunity to switch and say, look, I did this on this date. This is what it told me. And the information was not correct. That's a step that we didn't have before. So you might as well take advantage of it. Next slide. So when you're doing it, I've already talked about most of this, but it's going to give you a comparison. You can do a side-by-side comparison of 3 plans at a time, and it will tell you, is your pharmacy and network, is how many of your medications are covered? Is it cheaper if I go to CVS, unless I go to Grand Pharmacy, unless I go to XYZ Pharmacy? And I'll tell you the status of the cost. Each drug plan, each pharmacy will have a different cost for the medication. So just don't assume if it's $0 at this particular pharmacy, it's going to be $0 at all pharmacies. So it's important that you do an in-depth review and compare. And it will be plans just for your particular area. In New York, 10 drug plans, everybody gets the 10 drug plans. For Medicare Advantage, it depends on your particular county or borough. Even in New York City, each borough has a different amount of plan options. Next slide. So I just went through that. In addition, it's going to give you more information about those perks, what you can get, and the existing benefits that are going on in the Medicare Advantage. So when you're having conversations with people, or if you yourself, when your next door neighbor tells you that they have the best plan, please do not just assume that just because it's the best plan, it's the best plan for you also. Because healthcare coverage is not a one size fits all. It's all going to depend on you, your medical need, your prescription needs, your wants, and your income, and what you are and are not able to afford. Next slide. So you want to personalize, don't compare it with anyone. Different healthcare needs, different healthcare medications, and not everyone qualifies for the same coverage. Most people aren't going to tell you, oh, by the way, I'm on Medicaid and that's why my coverage is great, or that's why I'm paying zero. They're not going to admit that they're a lower income individual. So smile at your neighbor and just have my voice in the back saying that's the insurance is the best for them, but not necessarily for me. In addition, you don't know if the person has coverage through their employer or their union. As I started this, nobody knows what they have. Nobody knows what they what the plan means. They just know they have Empire Blue Cross Blue Shield doing business as Anthem. So it's very important that a person is active, they do their research, or they find somebody who can do their research for them. Next slide. So what are you looking for to minimize your headaches? On January 4th, you want to be able to walk into CVS and know, I've done my research. I'm going to get my medication. I'm going to get my medication in the least expensive way, and I'm using the proper pharmacy. And most importantly, you want to make sure that if you decide not to switch, that your plan is going to be available in 2026. As for people who have Medicare Advantages, next slide. In addition to your medications, you also want to make sure that your doctors are in network, that your copay that you are paying $5 continues to be $5, or maybe you're lucky and it's now zero, because that will change, or your deductible or your copay for when you go to the hospital per day is the same amount. And you want to make sure that if it's an HMO or a PPO, so that if your doctor no longer contracts with your insurance company, but you decide to stay with your plan, does it give you the opportunity to pay a higher amount of money to see this doctor? And if you're in original Medicare, is maybe looking at a Medicare supplement the way to go? Next slide. Before we do that, everyone usually says to me, so what is it I'm supposed to do? Do I go Medicare Advantage? Do I do original? That is truly a personal decision, and it depends on what you want and what you need. I give the example of my parents. My father would tell you that he's an original Medicare person. He's going to go to the doctor, any doctor, when he wants to go. He doesn't mind being billed after the fact, but he's going to see the doctor he wants. If he woke up with a headache, he's going right to the neurosurgeon, and he's not going to his primary care doctor, who's going to get him to a neurologist, who's then going to get him to the neurosurgeon. My mom, on the other hand, would think, oh, look at this, a Medicare Advantage. They gave me this book. The book tells me the doctors. I know exactly how much my visit is. I'll have my $20 in my pocket. When I go to see my primary care doctor, I'm going to have a conversation. Dr. Sacker never gives me wrong advice, and he'll get me to a specialist who will be able to help me. He'll be able to help me get the prior authorization I need for the next level of care. Individuals wants and individuals needs. Finally, once again, our reminder, if the person has union insurance, retiree insurance, veteran insurance, they need to proceed with caution with if they wanted to move into a Medicare Advantage plan or a standalone Medicare RX directly through Medicare. Because once they move in, there's the possibility that they're not going to get what they had before. So they need to proceed with caution. Next plan. So how do you make make your plan changes? I did all the research. I realized that Silver Script Choice is no longer a benchmark plan. I don't want to pay $120. I certainly don't want to pay $58 a month because I have extra help. What do? I've done the comparison. I found a cheaper plan. I can get all my medications under a benchmark plan. What is it that I do? First, either yourself or you've spoken with a counselor, either through our program, through Medicare Rights, through the state high cap office, and they've told you, okay, this is what our researchers showed. You've listened to them. You said, okay, I agree. I want to move. You can enroll directly through Medicare Plan Finder, either going in my Medicare.gov account, or if you go on the Plan Finder and you find the plan name and ID number through the search, you can just hit the green button that says enroll, and then it talks you through a 7-page, which is really not 7 full pages. It's actually very user friendly in that you could actually enroll right then and there. We'll give you a confirmation, and then in December you will get your new plan information so that you can give it to your pharmacy on January 1st, or give it to your doctors when you come. Who can do that on their behalf? The person needs to be a Medicare authorized representative. So if the individual themselves can't say, I agree with all this, let's do this, while you're with them, you're going to go through the website with them, you're going to answer the questions based on their answers, then they would need to have either a power of attorney, a healthcare proxy, or a court-appointed guardian. Next slide. I'm going to hand it over to Rebecca, and she's going to take it from here.
Thanks, Kelly. But I just want to make it clear that on the last slide that, the beneficiary can appoint a representative. I think Kelly said it, but just who is a family member or an attorney or a social worker through the process and help them enroll. Or they can call 1-800-Medicare, as Kelly said. So in these last couple of minutes, I'm going to try to speed through the state and federal programs that exist to reduce out-of-pocket costs, and maybe we'll have time for a couple of questions at the end. The first one is called EPIC, or the Elderly Pharmaceutical Insurance Coverage Program. This is a state-run prescription drug program only for people who are over 65 with an annual income of up to $75,000 if they're single, or $100,000 if they're married. So it's a pretty expansive benefit, and it does really reduce your out-of-pocket costs. There's 2 tiers. The lower income you are, the more benefits EPIC provides. It's an easy application. We have a link to it right here, and it does give you a step. So sometimes it's a strategy for a middle income person to change their plans in the middle of the year. Extra help, we've referred to it a lot of times in this presentation. It's also called the Low Income Subsidy, or LIS. It is a benefit that's run through the federal government, and it's a great program for those who are eligible because it pays the monthly premium, and it also eliminates the annual Part D deductible, and it reduces your copays. And we have the list of how it does it here. The income and resource limits are stricter than you'll see in our Medicaid program. So we have the income limits and the resources up here. For some individuals, though, who have low income and lower resources, this apply and they don't have Medicaid or MSP, it can be very quick to help them apply online. And we've provided this SSA.gov URL below for someone who really can't access their prescription drugs at all based on cost. If they meet these criteria, applying online is very quick. But we're lucky that in our state, we have more expansive eligibility and for the Medicare Savings Program and even Medicaid. If you have Medicare Savings Program or the Medicaid program, you're automatically enrolled in Extra Help. When we have more time, we have a slide about MSP. We talk about how it rocks and we go through all like the wonderful things that MSP does. This is an amazing program that puts money back in our clients' pockets for any Medicare beneficiary. The state's MSP program pays the $185 a month Medicare Part B premium, which is probably going to go up to over $200 next year. So we're talking about putting like $2,000 more a month into someone's pocket. It automatically enrolls them in Extra Help, eliminating the deductible, reducing the premium, and their co-pays at the pharmacy are very low. So it's estimated to be worth about $5,000 per beneficiary who enrolls. And we know that there's probably over 300,000 New Yorkers who are eligible for this program who haven't enrolled. Last year, when we were doing our Medicare clinics, we found a lot of people who were eligible. You can too. You can see the income requirements here. There is no resource test. There's no resource test. So you're evaluating income based on non-Magi budgeting rules. We also have Medicaid, which has the same income limits as the QMB program, and it also has a resource test. We've listed those eligibility criteria below. Medicaid works as a wraparound and automatically enrolls people in Extra Help, and it also covers additional services that Medicare doesn't cover, the big one being long-term care, but also medical transportation, because it can be very expensive to get to the doctor, vision, dental, audiology also covered, not covered by original Medicare, but sometimes covered on a very limited basis in Medicare Advantage. And we did already talk about these supplements, but that can be a possibility for people to reduce their costs or pay them differently. And if you're feeling like you'll never figure it out, don't worry, we're here to help. And so is the SHIP program. Here's our contact information. And you can all take away messages for your clients that now is the time to act between 10:15 and 12:07. And to get the assistance of a trusted professional, if you have questions, don't pick a plan just on premium costs alone. Look at all of the costs. Make sure that your drugs, your providers, your pharmacy, they're covered. And we do know that there are aggressive marketing scams. So we've provided the phone numbers here for where to report those. It looks like we're coming up on the end, but Kelly, I wanted to, of our time together for this quick hour on Medicare open enrollment, but do you have anything that you want to add, Kelly, or questions that you want to sort of answer that you wrote verbally that you provided written answers to?
Sure. So in one of the questions pointed out that Cigna had drug plans in 2025. However, if you would look at the list, it doesn't appear that they have drug plans. They do have plans. However, those plans are now being marketed as HealthSpring RX drugs. People who are in those particular plans do not have to do anything if that's where they want to stay. It's going to be, instead of Cigna Insurance, it will be HealthSpring Assurance RX, but the plan ID number is the same. We did have a question in regards to if a person has expensive medications, what do they do? If you have a SEP and you can get them to move now, you try to research to see if there's any plan that's covering it. You also want to check to see if it's if it's being covered by Medicare Part B instead of D. So that's some of the perks. If you're not sure if it's covered or not, you type in the name on the drug plan search, and what happens is nothing shows up. It probably is not, but I am a very good user of Google, and you just say, is such and such covered by Medicare? And the information will come up with this response.
And one thing to add
Um,
on that one, if there's not a SEP available to a beneficiary in that position, there is a process to ask the current drug plan for an exception and to cover that med if it is covered by Part D. And we've had clients who've been successful with those exceptions. You're going to need the support of a physician to pursue that. So that may
that's
be an
good.
option as well.
Right, and if the person is in Epic, just remember you have your Epic SEP once a year. If they're not in Epic and they would be eligible to be in Epic, they want to enroll, they want to get their Epic number, and then they're going to use the special enrollment or the get out of jail free card once a year. Other than that, I hope that we've made you all Medicare experts. And if you have become a Medicare expert, please give us a call and we would love you to come volunteer with us because we have loads of cases because we're a very small unit. We're mighty, but very small, and we're trying to help the needs of all our older adults and disabled individuals to get their care in the least expensive way possible.
Thank you, everybody, for your time, and we will be in touch with copies of the slides and the let you know when the webinar is posted. Have a great rest of the afternoon. Thank you.
Bye.